Hey everyone, this is Ryan with Curbside to Bedside. I'm here with Floyd, and in a bit of a deviation from protocol per se, we have decided to bring in a third voice into the mix, and this is Dr. Walt Lubbers. He is actually a area medical director for one of the agencies that Floyd and I both work on. He is a familiar face, a consummate professional, a educator of many paramedics and residents, a generous lover, and I will let him introduce himself.
Hey, how's it going? Emphasis on the generous, indeed. Yep. Hey, how you doing, Walt Lubbers? Pre-hospital physician, ER doc. Happy to be here more than anything else.
So you can tell that he loves to talk about himself. He's just so long-winded when you ask him what his background is. We're going to give you some more details on the website, but he really wants to get in to what we're going to be talking about today, and that's the topic of pre-hospital cardiac arrest. And you may wonder why we're having a physician talk about how we should manage a pre-hospital cardiac arrest. Well, he himself is a EMS physician. He completed an EMS residency, and he rides on an ambulance from time to time. So he's very practical. So Dr. Lubbers, to start us off, I thought you could teach us a little bit about maybe the physiology of cardiac arrest and how that should shape or change how we manage a cardiac arrest.
Sure. So cardiac arrest itself, we sort of have always thought of cardiac arrest because the way we've always known cardiac arrest is that you clutch your chest and you drop and you're dead. And that's the way that humanity has known what cardiac arrest is. And we've tried to do stuff about it, but the point where we've actually been studying it with really any kind of idea of what might actually been going on has been relatively new. So that's in the last half century or so. So one of the most, I think, insightful and revealing things that folks have come up with is starting around early 2000s or so. This idea that there are stages that you go through, that cardiac arrest is not just a thing. It's not just a drop. It's a series of events that actually happen in your life. And this mostly looks at shockable rhythm. So VFET, PEA, honestly, if you go into PEA, you're kind of fucked. There's just not that much that you can do about it. And the reason that you probably went into PEA is probably a pretty bad one. So survival is terrible. So we tend to look at the VFET stuff because that's stuff we can do something about and something that we can interrupt the process of. So your first, you're going along, you clutch your chest, and Brian, because you've been smoking for 60 pack years at this point, you fall over dead, and you've got an MI.
Not uncommon here.
Yeah, let's stick with what we know. So the first thing that happens is you go into VFET, you lose perfusion to your brain, you pass out. That we kind of know. What goes on in your heart at that point is sort of an interesting little bit because you start into a couple of phases of it. So the first maybe 2-4 minutes of the time that you're fibrillating or VTACing without a pulse, you're in the electrical phase of cardiac arrest, which means you're fibrillating. You've got all these weird rotor currents that are set up from injury and potassium channels doing weird stuff. But if you defibrillate somebody in that first couple of minutes, the chance they're going to come back is pretty high. So that's why they call it the electrical phase. You've still got enough ATP or substrate in your myocardium that if you shock it, it'll probably develop a rhythm again, at least most of the time. After that, you're 4 minutes in or so, you've lost a lot of that myocardial ATP and you've lost the oxygen, you've lost the glucose that's actually going to power the cells. And so even if you shock, if the person's still fibrillating, even if you shock them, you may terminate the VF, but they will likely go into either a sort of an agonal PEA or a asystole at that point. So after about 4 minutes of no perfusion, you're looking at the hemodynamic phase of cardiac arrest. And this is the point where we can actually do something. Up till 2-4 minutes, the most important thing is getting the shock in. After 2-4 minutes, you've got to restore some perfusion back to the myocardium. Otherwise, your shock's unlikely to be successful. Not to say that it couldn't be successful, but it's less likely to be. And so at that point in this hemodynamic phase, up till about 10 minutes, what we need to be focusing on is restoring hemodynamics. So this is where epi probably works if you believe in epi. And not everybody does, but I think there's probably still a role for it. This is where great CPR helps. This is where restoring volume, if it's a hypovolemia issue, works. After about 10 minutes of at least VF if it's untreated, and you can stretch that time out a little bit if you get good CPR. But after about 10 minutes, you're in the metabolic phase, which is basically like a whole crush injury to the body. All the tissues have gotten ischemic, and even if you restore perfusion to it, they've now got this huge problem that they've got to overcome, which is the post-cardiac arrest syndrome. So you got superoxides floating around different places and calcium flying everywhere and potassium moving in and out and doing all kinds of weird shit. And it's really hard to come back from that. Even if you get the person, hemodynamically back, if you get their pulse rate back, the rest of their body, because of all that crap that's going on, is going to have a real problem. And so you still end up developing multi-organ system dysfunction, and you still have a predictable crash about 2 hours later after you get ROSC. So you try to keep people out of that metabolic phase. And that's where good resuscitation, if you can push them back, you can extend that phase out, that hemodynamic phase, you can extend out to 20 minutes, 40 minutes, something like that. If you're really working, it's a young person with good substrate. So those phases of cardiac arrest are sort of important to know because they might dictate what you do.
When someone drops dead in front of you, let's say it's truly a sudden cardiac arrest, they initially go in that electrical phase. And you said somewhere along the lines of like 2 to 4 minutes, which generally our response times are, if we're lucky, 5 minutes, but usually probably more realistically around 8 minutes, we get out of the electrical phase. And I think of the electrical phase as someone being in like very coarse VFib or VTAC, something we know that if we shock, we're likely to restore that person to a perfusing rhythm. But is it true that you can actually reverse the phase? Let's say they're going in the metabolic phase and they're in coarse VFib or they're in fine VFib, and we know that if we shock fine VFib, they're probably going to go into asystole. But if we do good CPR, you can reverse that and increase the chance of a successful defibrillation. True?
Yeah, that's what a lot of folks have postulated. So you've probably heard at some point, you should do, pick your number, 2 minutes of CPR before you shock, 4 minutes of CPR before you shock. The theory is exactly that you restore some perfusion back to the myocardium, you decrease some of the hemodynamic insult, and you increase the chance that you get a successful defibrillation. And that you go back to a perfusing rhythm after that. And that 2 minutes is it's based on some studies that they're good studies, but they're a little bit misunderstood, I think. Most of them, it's usually not that you need to wait 2 minutes and do CPR and not shock if you can. What usually probably happens is if you look at like Steele's article on it, it took them about 90, your best survival comes at 90 seconds after they arrive, where they were doing, if they do CPR for 90 seconds after they arrive and then shock, they get better outcomes. That's probably because it takes you, honestly, you guys run this in the field more than I do. How long does it take you to actually get pads on somebody, even if you know it's an arrest?
Probably longer than we think.
Yeah.
Probably
I can tell you
longer than most people.
If they have a shirt on, you've got to get the shirt off, extend the cables. You got to find the
trauma shoes. You got to fumble with it. You got to get through 4 layers of clothing. Yeah. You got to fumble with the packaging. And
so maybe
pads on.
Maybe 2 minutes. It depends on the patient, really.
There have been times where you could go through an entire round of CPR before actually getting successful pad placement on someone. And that's assuming you actually take the time to put the pads where they need to go and not just slap them on.
I can tell you in the lab in the hospital where we train people, train hospital teams who know that the patient is in VF, and who know that what they need to do is put the pads on them and shock them. It takes usually about a minute and a half to actually make the mechanics happen. And that's a relatively big team, on a relatively unobstructed mannequin. And we throw little things in to kind of make it a little longer, but it takes you about a minute and a half to even get the stuff logistically together. So my advice to most people is, you probably don't need to actually do 2 formal minutes of CPR. What you probably need to do is do CPR, get the pads on, and by the time you get the pads on, it's probably been about 2 minutes anyway. So focus most on doing CPR first, and then try to shock as soon as you can, because you also don't know how long the guy's been in VF until you put him on the monitor. He honestly may have just gone into VF a minute ago because you weren't there. You don't know. Yeah. So that's part of it too. I will encourage people to say, yes, do great CPR until you get the pads on. And as soon as you get the pads on, as soon as you get the monitor on, you're ready to go. Stop for a second, see where you're at. And if you can shock them, go ahead and shock them.
So I have a question that just kind of popped in my head. since we know that it's preferred to shock someone in an ATP-rich environment, which is why we do quality CPR. We have a short pause shock, and then we get back on the chest. And most of our very fine VF patients are converted into asystole. Should we be shocking patients with very fine VFib?
Well, there's always the chance that they'll go back into a good rhythm. So they're not probably going to spontaneously convert out of VF, even if it's very fine. So if you're actually in fine VF and it's not just artifact from the ambulance bouncing up and down the road, which, by the way, I don't know why you'd be doing CPR in the back of an ambulance unless it just started in the back of an ambulance, but whatever, we'll talk about that in a little bit, I'm sure. Anyway, if you see fine VF, it's still probably okay to try to shock it because they are absolutely not going to come back out of it. And that's not to say that even if you're in an agonal rhythm, if you restore perfusion back to myocardium, that doesn't mean that it won't get better. You do convert them. Everybody basically has to convert from VF to a PEA. If you watch people, as soon as you shock them, they're going to convert into PEA at least for a little while, even if it's a decent QRS complex and all that other stuff that you might look at. For a little bit, everybody's going to go into PEA, and that's okay because PEA is still not the end. You can come back from PEA if you had enough substrate behind you to get you there. It's the guys that spontaneously went into PEA because they didn't, they are hypoxic or they had some sort of weird metabolic disturbance or something like that. Those are the guys that have the terrible, terrible outcomes.
Ron, you have any other questions?
Would you consider that the phases of arrest are more or less linear? Or do you think that much like in a mass casualty incident where you can have a patient that bounces between 2 or 3 different triage categories that you could kind of go back and forth in the phases of arrest, so metabolic, hemodynamic, or something like that?
Oh, yeah. You'll see, like everybody develops a little bit of the metabolic syndrome, or not the metabolic syndrome, the metabolic sort of injury, the stuff that happens. Everybody kind of develops that eventually. Mm-hmm. If you're in a low enough flow state, everybody's going to get that same kind of stuff. But you can certainly push people back from being kind of, late hemodynamic phase, fine VF. As you've probably seen, you do a round of CPR and they're still in fine VF. You do another round of CPR, give them a little bit of epi and maybe some fluid, and now they're in maybe coarser VF, and you give another one and then they actually shock and they shock out of it. Then they're in PEA, and then you give them another round of CPR and they get better still and their rate goes up to like 80, and maybe now we're looking for a pulse and that kind of thing. So one of the big important points is that time, while it's a linear slope going down, if you push on the person's chest really good and you ventilate them really good and you give them drugs, if you believe in drugs, you can push that curve out to the right for a long way. Okay. 30, like I said, you could do CPR for 30, 40 minutes in a young person, still have a good outcome if you do really good CPR.
And I will say that there are plenty of documented cases. There are a lot of patients who are worked for a long time, like over an hour, who still survive neurologically intact.
Yeah. And we can talk about that more too. But a lot of the recommendations that are coming out now, or at least the papers that are making any recommendation on it, the longest that they practically think you should do CPR is something like 47 minutes if you're in the right set of conditions for it.
And they keep extending that time out.
Yeah, because you get one more survivor. One more survivor means something to somebody. So yeah,
it means a whole lot if you're that survivor.
Yeah. If it's me, then work me longer.
So when it comes to pre-hospital interventions that are performed by the responding EMS crew, what is it that we do that actually makes the most difference in patient outcome or survivability?
Early transport. No, I'm kidding.
You've got to be shitting me.
No. So in terms of the things they're really effective, if you look at, like, say, what the Seattle guys say, or really what we should be doing just kind of as best practices, it's all the BLS stuff. Honestly, you guys are cool. You guys are awesome paramedics. But you sort of don't do shit in cardiac arrest. Your BLS partner is the guy that does most of this stuff. So all the high performance CPR, and by the way, I'm just sort of talking tongue in cheek. I don't have anything against paramedics out there. You guys are awesome. You should keep doing a good job. You're needed in cardiac arrest, but the stuff that we can measure that makes concrete difference is the stuff that our BLS providers will do.
Absolutely.
Or that they would own, typically. That doesn't mean that ALS shouldn't own that part too. But this is stuff that can be run by a BLS crew for the most part.
It's fully within, in my opinion, I think a lot of the data that actually comes out that shows what makes a discernible difference in cardiac arrest is BLS-owned CPR, wholeheartedly. Mm-hmm. That's in the wheelhouse of every EMR, every EMT, and arguably most, at least marginally trained bystanders could make a meaningful difference in the outcome of someone that suffers an out-of-hospital cardiac arrest.
Yeah. So, like, what are some of the things that make a difference in cardiac arrest? Well, it's chest compressions. That's one thing. And chest compressions aren't everything. If you've got something else that you can do that's more important than chest compressions, you should do it. But for the most part, we don't have a lot of those things pre-hospitally. So doing great chest compressions, and how do you actually make that happen? That's one of the things that we've tried to focus on, doing our in-hospital stuff, and to some extent doing our out-of-hospital stuff. How do you actually get somebody to do the appropriate chest compressions? Well, it's up between 100 and 120. Okay, cool. How fast is 100? Well, it's staying alive. Okay, cool. How fast does staying alive go? And nobody says anything usually.
I think I've heard you hum that before. Can you do that?
So when we ask people to do it, my impression of somebody else doing an impression of staying alive is staying alive, staying alive, staying alive. I can keep going if you want.
No, we're good.
I'm cool. Enjoying this.
Okay, we'll hit it back at the end of the show. Anyway, but then you stop and say, like, no, that's not staying alive. That's your sped up version of staying alive. Staying alive with the actual tempo of 120 is more like something like that. It's painfully slow. And, so I usually use, well, if we're between 100 and 120, what's 120? 120 is, Journey. It's Don't Stop Believin'. And if you play Don't Stop Believin', you'll probably play it a little fast too, but it's not fast. It's a slow groove. So trying to actually focus on the actual, yes, this is 100 to 120 makes a difference. And why does 100 to 120 really make a difference? Well, because if you study it and you look at it, folks that get compression rate between 100 and 120, and I think the sweet spot in the Idris paper is actually like 124, if I remember correctly, but 120 is easy enough to remember. If you target for 120, if you go less than 100, folks don't survive very well. If you go more than 120, folks don't survive very well. So everything in cardiac arrest resuscitation is a bell curve. There's no upper limit. If you push 180 times a minute, you're not going to do very good CPR. And that's been meted out in pretty much every study that's ever looked at it. You do poor recoil, you push too fast, you don't give the heart chance to refill, you tire out too quickly, you don't push deep enough, you push too deep. If you're going too fast, you're not doing it right. And it's not about doing it as fast as you can, as hard as you can, despite what people say. It's not push hard, push fast. It's do it right. Likewise, how do you know when you guys are teaching people, you guys teach people to do CPR, yeah?
Sure.
At some point?
Yeah.
Sure. You guys are both educators. How do you teach somebody to push, 2 inches? What's 2 inches actually look like? And more to the point, what's the upper limit of that bell curve? What's 2.4 inches actually look like?
I don't know that there's any good objective way to measure depth. I mean, just push hard and push fast, right?
As far as without the aid of some sort of assisted CPR device, I don't know that there really is a objective way to measure exactly 2.4 or 2 inches worth of depth on the chest.
Right. And the point I'm really kind of getting at is like, it's really tough. Yeah. You've either got to have something that's telling you you're going about 2 inches down, which you can argue about whether or not, I think Zoll's got the accelerometer on it. Not to plug Zoll, but if you ask the physio guys, they'll say, oh, that's bullshit. Don't listen to them. That's complete horseshit. So you're right. That's the tough part is like, how do you actually know? This is supposed to be a really important thing, right? You got to get 2 inches down. If you don't get 2 inches down, these guys are going to die. And if you go more than 2 inches, then you're going to kill them as well. And realistically, the difference between 2 and 2.4 inches is about the width of a pencil. So you got to hit that target that you don't really know how big it is, pushing down on some guy that you really don't know what 2 inches was to start off with. Like, it's really tough. So feedback devices are helpful. And I guess both companies, both of the big defibrillator companies around here, at least folks that they have things available, but they're not 100% and they're not cheap either. There's that. or I guess you could practice it really well on instrument and mannequin. But even then, how do you know if you get your 2.4 inches down? How do you know you're staying on it? Because the one thing that we have seen is that everybody starts off CPR great. Like you start off and you're, yes, 2 inches every single time, and you're going at a rate of 100. And then by about 40 seconds in, it's no longer 2 inches at all. It's about 1.5 inches, and then it's about 1 inch.
When you look at mechanical CPR devices and compare that to quality manual CPR, there's like no good evidence that they're any better than just good quality standard CPR. And they provide consistent rate and depth.
Right, which is why if you read the headlines and you don't actually follow through with it and you don't think about what the studies that are done actually mean, the mechanical CPR devices, you think like, oh, okay, why would I spend $15,000 on something that's no better than anything than I can do with my hands? Well, that's $15,000, something that somebody can't do better than with their hands, but not necessarily you, honestly. And nobody wants to be told they're bad at doing CPR, but there's a lot of us that are bad at doing CPR.
That's true. Bagging people.
Yeah. Between the two of them, yeah. The mechanical CPR devices have been compared against places that do really good CPR because they're good enough to be a study site. So you got to have a pretty good EMS system. They do regular training. Those are the guys, the really good guys, the Seattle guys, those folks, those are the quality of guys. And it's not just Seattle. There's a bunch of other places out there that do really good CPR, but that's what you're comparing against. You're not comparing it against, Billy and Joe, who were working, and God love them because they're putting themselves out there and they're responding in their community and they're helping out, but they can't train that much. They don't have that much money. They don't have that much for education. You're not comparing those guys to the Lucas device. You're comparing the guys that do nothing except CPR to the Lucas device. Or you're comparing the Lucas device to folks that have only used it maybe 40% of their arrests or something like that. So it's really hard to actually, I think it's really hard to still say that the mechanical CPR device is probably not better or has some advantage to most of the CPR that goes on out there, because most of the CPR that goes on out there, especially in the hospital, is kind of crappy.
It's not better than the best manual CPR, but I mean, why would you expect it to be any better than the best manual CPR to begin with?
Yeah.
Because the two would, if they're both the best, then they would be equal.
Yeah.
So
sort of like where you mentioned ventilations. There have been a couple of studies that compared continuous ventilation or continuous chest compressions versus 30-2 compression ventilation ratio. And they found no difference between the two. Well, they found no difference between the two because their pauses for ventilation, instead of being like 8-10 seconds long, like most people's are, their pauses for ventilation were like a second, and their pulse checks were like 3 seconds. And the groups were essentially the same in terms of the CPR quality. Both had a chest compression fraction of right around 80%. Both had basically the same time, hands off chest time. That's the stuff that, that proves what? Not that one is different or not that one is better, just that you can do really great CPR 30-2, or you can do really great CPR continuously. As long as you're doing really great CPR, it doesn't really matter when you do it.
Yeah. As long as you train like hell.
Yeah.
One way or the other.
Absolutely.
So we kind of got into this already, but we've talked a lot about good rate, good depth, just what it means to provide quality CPR. But you mentioned earlier high performance CPR. In your mind, what does that look like in action? Like if you had a crew in front of you and you said these guys are performing high performance CPR, what exactly would they be doing?
You'd be doing chest compressions between 100 and 120 beats a minute. You'd be on the chest for more than 80% of the time. You would be ventilating with appropriate tidal volumes, probably no more than 500 milliliters of air per tidal volume, and you'd be going at a rate of about 10. You'd be doing full chest release with every compression. And your pre-shock pause would be essentially 2 seconds. Your post-shock interval would be essentially 0, and you'd be back on the chest essentially right away. So I think one of the things that we don't really think about real often is what is high performance CPR, and everybody thinks, well, it's pushing hard or fast, or it's doing X, Y, or Z. But I think really what makes high performance CPR in the way that it's described or with the way that it's most useful is that you actually set out the parameters for it and you see that you're meeting the parameters. It's really not an objective. Oh yeah, well, we could say that Floyd's doing high performance CPR, but because he feels good about it, but that's really not the thing. It's actually attaching parameters to it and doing those parameters. And that's what makes high performance CPR an actual thing.
So to boil it down in a sentence, high performance CPR is entirely measurable. It's not something that I felt that code went good. Right. That's the end of it. It is a actual data point that matters. It is clinically relevant measurement to that patient.
Right. In my opinion, you can't be doing high performance CPR unless you're measuring all the components of it.
So if I was the lead on a cardiac arrest and I wanted to assign roles to everybody and I wanted to do high performance CPR, otherwise known as pit crew CPR, what should all the rotations look like? How should everybody be organized?
Well, hopefully you've organized them ahead of time because it's going to be tough to do on scene. Not impossible, but it's going to be tough to do because there's so much stuff that has to happen. One person's going to have a really hard time doing it. So without having people assigned to those tasks kind of ahead of time, and just like a pit crew, if you actually look at a pit crew, the secret to the pit crew is not that everybody's a great mechanic. The secret to a pit crew is that they just train like hell and they know exactly what they're supposed to do, and it's highly choreographed. So if you rehearse it a lot, if you train a lot on it and everybody knows exactly what they're supposed to do at any given point, you can kind of predict. The team leader itself really doesn't have to do anything other than talk to the family and look at the monitor, because everybody else, you could tell, okay, if you got a really high performing team that's really well trained, you could say, I'm at 1 minute in. I know that, Billy is going to be doing chest compressions and he is a minute in. So he's going to be getting tired. So we're going to be getting ready to switch out, and Joni is going to be right behind him. And, Frida is bagging every 10th compression just like she's supposed to. And so if I know what time in the arrest I'm at, I can tell you exactly what should be going on. That's obviously a really, really high performance, really high practice team, but that's the essence of the pit crew, I think. If you're trying to make it up like when you get there, that's cool. But it's a little bit harder to do, and you kind of gotta be aware of everybody out there. In which case, the team leader or the lead paramedic or whoever it is, my advice would be start everybody in the role that they're supposed to perform. So, chest compressor could be an ALS provider, it could be a BLS provider, it could be a trained bystander, an EMR, or anybody that's out there if they can do good chest compressions.
I've used family and coached.
It would work, yeah. If you were...
it wasn't the most ideal, but sort of against the grain and conventional belief amongst some of the other providers I've talked to that was actually tended to be, in my anecdote, a more healing experience for the family. Because I think that's a lot of impedance to progress. And this is kind of getting off on a tangent, but our perception of what is and is not harmful to a family without actually asking them what they think is or isn't harmful. And we'll get into this later, I'm sure, but like the working on scene. Mm-hmm. A lot of people are like, well, this is traumatic. Well, have you ever asked a family? They're noticed that they're distraught because their loved one is dead in front of them. But is it more healing to be an active participant in that process? Or is it more healing to have a bunch of strangers come into your home, snatch up your loved one who has died in front of you, and take them off into basically 45 minutes is the great unknown? And then get to the hospital and sit in a chapel room where the writing is on the wall, and just be told the inevitable without ever having really participated in the process.
I think there's a lot to be said for that. Like, if you think about some of the stuff you'll do some of the stuff they let families do in like children's hospitals when a child dies, and not that you want children to die, but that's a really traumatic time. We sort of are a little bit more callous to adults, but think of the stuff that they do. Like, the worst thing in the world is to sit and be helpless as your child chokes in front of you. Like, that's absolutely awful. And you feel the same way about anybody. That's really the feeling of being powerless is, I think, one of the things that's probably one of the worst things about it. So I think you're right. Like, if you can incorporate a family if they want to, especially if you're in a resource poor environment, like we might be out here sometimes where you got two providers and hopefully somebody's going to show up at some point. You got two people and somebody's got to run this thing. If the family's willing to help, then you've given them something to do and they can participate. They can help the family, or they can help their loved one. They can do something. They can actually get their hands in there and try to bring the person back. And no longer are they now a participant, or no longer are they now a bystander that just has to watch their loved one die. You've given them something to do.
At least in my mind, that's incredibly important, because I think all too often we get caught up in the you called me mindset and the I'm the expert, and we end up stonewalling the most important people in these patients' lives out of their life at what could be the last moments of their life, if that makes any sense. I think that there's a twist there that most people would not agree with if you were sitting across the table talking to them. And as long as you have the interpersonal skills to coach a stranger, and you should if you're working this job because you deal with strangers every day, through a stressful event with someone that's compliant, then there's honestly, in my mind, no reason to not incorporate them, because we've already established what good CPR looks like. They don't have to work the monitor. They don't have to drill the IO. But I can sit next to a family member and be like, okay, you just need to push a little bit harder, sweetie. Like, just down a little bit further, come completely off the chest. They're doing something. They may only have to do it for 20 seconds. But that's all they need to feel like they have fulfilled their role. Mm-hmm. And then move on. And I think that's something that's really not talked about. ACLS does, honestly, a really shitty job. They're like, bring the family in. Tell the family what is going on. Make the family... Okay, you're making the family an active participant, but in what? It's basically just like a spectacle of death. That's all they're doing. They're sitting on the sideline. I'm not saying you need to retch every person in by the scruff of the neck and be like, do CPR. But if they're like, man, I really want to do something, and that's a lot of the people that we deal with, at least where we work, is hands-on folks. Mm-hmm. And that's generally the consensus of the people that we work with, is they want to do. They don't want to sit back and watch and be told what's going on. They want to be involved. So, that's gonna vary. And this is one paramedic's anecdote talking to a microphone. It's not representative of where you work or your experience, and that's fine. But where I work and what I've seen, and this is not the evident truth, is people really, really, really like to be involved in the people they love about's life or the end of their life. And I think that one of the best gifts we can give someone, regardless of how you feel about cardiac arrest, if you're really enthusiastic about it like Walt and Floyd...
I was going to say, I'm against it.
But I'm just generally not a fan of cardiac arrest. I think it's a pretty shitty time.
I derailed you. My apologies.
But there's a lot of nihilism around cardiac arrest, too.
Yeah.
And I see it mostly in peer groups. And it affects everyone. Mm-hmm. And I don't think it's justified.
Yeah, I agree.
Not because I have a misguided notion that we're going to get every person that we lay hands on back. I think it's a missed opportunity to make a difference in somebody's life. And that somebody does not have to be the patient lying in front of you whose pulse is synaptic.
I think the nihilism comes from, people being like, oh, we never get anybody back and no one ever survives. But that's not true, because if you do things right, people actually do survive. But you're not seeing a lot of people come back because you're probably working a whole lot of people who shouldn't be worked, or at least you're transporting a whole lot of people who shouldn't be transported. Yeah, when there's no chance of a meaningful outcome. We're working people when there's absolutely no chance of that sort of outcome.
It's a snake that eats its own tail. And eventually, you just wind up back to where you started from.
I didn't know you were so philosophical.
I mean, occasionally, I can pull some shit out of my ass. It sounds real nice.
I had a few more questions on high-performance CPR.
Yeah.
And I know that we've discussed a lot of, like, what are you going to do when you get to the patient's side? You're going to focus on quality CPR, minimal interruptions. Then you're going to apply the pads. You're going to analyze that rhythm, shock if needed. But I think the most important period during a cardiac arrest occurs about the minute 40, minute 45 mark. There's a few important elements of high performance CPR that occur during that time. Do you care to focus on that and tell us exactly what we should be planning for?
Yeah, well, I can tell you what I think is important anyway. And for the full 20 minutes of glory on how much I can talk about this, and 20 minutes was even condensing it down to more than I wanted to, check out emsgrandrounds.org and see our video on what to do during a pulse check.
Damn, that was a sly, shameless plug.
Wasn't that nice? So anyway, when you're doing, one of the most deadly parts of the whole resuscitation is the thing that should be one of the smoothest running. It's the pulse check, which should actually be a rhythm check because you don't actually have to check pulse, but we can talk about that in a second. So
we're super awesome at feeling out what's actually a pulse and what's not.
Yeah. We'll talk about that. So every 2 minutes, there's going to be a pulse check. Well, it's actually turns out that we aren't very good at calculating 2 minutes without a timer. So it turns into every 3 or 4, but kind of whatever who's counting. We are, because we're evaluating all these runs. So realistically, when you're getting ready to do a pulse check, we sort of think like, oh my God, it's 2 minutes, so we got to stop. And like, if I carry on for more than 2 minutes or something like that, then something terrible is going to happen to the person. Number one, that's not the case at all. What you should be doing is a bunch of chest compressions and getting ready. And if you're not ready to do your pulse check or your rhythm check or whatever it is at 2 minutes, then like, don't do it. Just keep on doing chest compressions. There's no reason to hurry this thing. Because the thing that is going to kill the person is if you stop doing chest compressions and then you sort of screw around for a while. Maybe you're looking for a pulse. Maybe you're like charging the monitor. Maybe, oh crap, the pads aren't on the patient after all. Something like that. Those are the things that are going to really hurt the patient. So if you look at, I think it was Chesky's perishock pause. Yeah. Sheldon Chesky's is 2011. If you look at his perishock pause paper, it really makes a difference. The interval from between the time that you stop chest compressions to the time that you give a shock, if a shock is indicated, and then the time from the shock to when you start CPR again, that really makes a difference. And all of us think like, oh yeah, that's like 10 seconds or something like that. We're following in the guidelines. Most of us aren't. The average time for these things, again, if you take them down to the lab, it takes about 21 seconds for most people to do a relatively straightforward VF pulse check with a shock.
Wow.
Yeah. And if you look at your runs, if you look at the actual files that the monitor will record off of it, you'll probably find about the same thing. We're sitting around doing a lot of stuff before we actually give the shock, and then sitting around what should be an automatic thing, shock back on the chest, shock back on the chest. We don't do that. We spend a lot of time out there, and every 5 seconds that you spend more than the initial 5 seconds costs the patient like 20%. I think it's 18%, but around 20% of their odds of survival. And that 5 seconds adds up really quickly. So probably arguably the most important time is from the time that you stop doing CPR to the time that you shock the guy. That's got to be fast. That's got to be almost instantaneous, but certainly under 5 seconds. And if you spend more time than that, you're hurting the patient. You probably should have kept doing CPR for whatever reason.
So that is truly a rapid rhythm recognition. I think a lot of what trips paramedics up is, shit, is that VFib or is that artifact? And then you start investigating.
Mm-hmm.
And I think the crux of the issue is, like you've elaborated, is essentially logistics. Is getting everything in its right place before you decide to pull the trigger. And I think we have a tendency to get wrapped up in the moment and be like, we got to go.
Yeah.
And then no one's like, okay, we missed our 2 minute point. That's cool, but we're going to do this right.
Yeah.
Instead of, shit, we're going to get QA'd, and I'm going to be like, why the hell did you spend longer than 2 minutes checking for pulse?
Yeah.
Well, I want it to set up my pulse check.
Yeah. So what should you be doing at a minute 45? Well, whoever's the team lead, or presumably whoever's the ALS provider, you should be getting yourself ready to give a shock, because you're going to hope for the best and assume that this is actually a shockable rhythm. So you can go ahead and pre-charge the defibrillator. You can do it 30 seconds till the time you're intending to stop. You can do it 10 seconds. Most defibrillators to get up to 200 take about 6-7 seconds to make that happen. So you can pre-charge the defibrillator. You should get yourself in a position to where you can see the screen and you're focused on the screen and you're thinking this is going to be one of 3 different things. Either it's going to be a squiggly line, in which case I'm going to press the shock button and I'm going to tell everybody else that they should just keep their hands off the patient ahead of time so that I know that their hands aren't there. It's either going to be the squiggly line, I'm going to shock it, or anything else, I'm just going to tell them to do CPR again. And so you're looking at that monitor, you're watching that, and okay, I'm going to be ready. And then you say stop. And when the person, leaps back and keeps their hands off the patient and nobody else is touching the patient, the only thing you've got to look at is squiggly line versus not squiggly line. And if there's not a squiggly line and it's not something that you think might even have a pulse, if their rate is 30, that's not going to be perfusing. Even if there was a little pulse behind it, who cares? Start doing CPR again. If it's asystole, why check a pulse? It's not going to be there. Jump back on the chest. If it's a squiggly line, it's not going to have a pulse. Go ahead and shock it. Don't do the pulse check. And that's the other thing that I think folks get wrapped up in is like, I got to feel if there's a pulse. You don't got to feel if there's a pulse. You can tell almost everything just from what the monitor looks at. You're really not interested in if he's got a pulse. You're interested in if he's got something that's going to perfuse the rest of his body.
Minimizing interruptions or minimizing pauses altogether are important, but minimizing the peri or pre-shock pause is the most. Right, because we want to do good quality CPR. We want to be able to lift the hands up, deliver a shock, and get right back down.
Right. It should be the pre-shock pause is probably, if you had to pick an interval, that's the more important of the kind of three that you can measure probably.
Because you want to keep that interval from the time you stop CPR to shock as short as possible, because you want to defibrillate in an ATP-rich environment. And I think what you were talking about, we don't need to be saying, I'm clear, you're clear. We don't need to spend 10 seconds doing all that. Pre-charge the monitor before you even do a rhythm check, because if it's not a shockable rhythm, then you can dump that charge. It's not going to hurt anything. But I think it's something that we have to train on. Like, our team has to know that, hey, the team has to know that at about a minute 45 in, I'm going to go ahead and charge this monitor, or you have to make that explicitly clear, because if you don't train on this with your team, you're going to hit that charge button and people are going to start moving away, because they think you're getting ready to shock them. And I think that good high performing teams do this so much that they don't even really have to communicate a whole lot about it, because people know that, hey, it's a minute 45. We're going to pre-charge the monitor. And they know that as soon as you pause, you're going to be shocking. You don't have to say, I'm clear, you're clear, we're all clear. It's just something that's going to happen. So everyone moves out of the way so that you can shock as soon as possible. And then someone else moves in, getting ready to do CPR. Does that sound about right?
Right. Okay. That's where the training comes in. If you honestly had to pick something, like you're in a, whatever you want to call it, you got a lot of part-time folks that you can't get in for training or something like that. If you had to pick one thing, I'd say if you've got one intervention to do, it's the pre-charge the defibrillator. Because that'll take you from a pre-shock time of about 15 seconds down to about 3 seconds. If that's one little thing that you can do that you as one person can do that. Because we don't all have the opportunity to practice with our partner all the time and really get that pit crew in there.
And if they're in VF or asystole, we don't need to feel for a pulse.
Correct.
Now, with the Lucas, I know that the manufacturer approves defibrillations during the Lucas. Is that correct?
As I recall, yes.
So theoretically, if you know that the patient's in VFib, then even if you don't pre-charge the monitor, and I've done this myself, is like we do a quick pause, check a rhythm. If it's VFib, we'll just start CPR again. We'll go ahead, charge the monitor, and we'll defibrillate the patient while the Lucas is doing compressions.
Yeah, you could do that. It seems reasonable. I worry about it a little bit, and this probably is an unfounded worry that, like, if you compress the chest, maybe you're actually changing that vector a little bit, or you're going to pull the pad off a little bit or something. I doubt that actually is a thing, but it just seems like, I don't know. So that's a question that I have, but I don't have anything to actually back that up. So long story short, yeah, that's probably just fine.
Just a quick anecdote, and I'm interested in if anyone else out there has ever had this experience. The artifact produced by the Lucas seems much less than the amplitude or the amount of artifact produced by manual CPR. So I've found it quite easy to see the patient's underlying rhythm, i.e. when the Lucas is going, or when I pause to do a rhythm analysis and it looks like clear VFib, when I continue the Lucas, the shape and morphology of the rhythm doesn't change, so that I know that it's the same. I don't know if this is actually a thing or not, but it's just an anecdote. It's just my anecdotal experience.
I've seen the same, especially in the absence, and it don't necessarily rely on it, but it's a helpful thing to have in the back of your mind, especially if you don't have like see-through pads or anything like that. And just kind of be cognizant of what your normal CPR artifact looks like on the 2-lead.
Yeah, and this was without see-through pads, and I've ran a code for almost 20 minutes before with 0 pauses in CPR, just because the patient's underlying rhythm was so clear with the Lucas performing CPR that we really never need to stop. We could basically just every 2 minutes just shock the patient.
And I don't think there's really anything that's holding your feet to the fire that says you must stop CPR every 2 minutes.
Mm-hmm. In fact, some folks are saying, once you establish that the patient is in either persistent VF or refractory VF or recurrent VF, maybe you should stop shocking every 2 minutes. Maybe you ought to stretch it out to 4 minutes or 5 minutes. I think the guys in Minnesota are kind of leaning in that direction. Like once you establish that a couple of shocks haven't worked, unless you think there's something else you've done that might change that, if you've given a bunch of epi all of a sudden or something like that, yeah, you could try it again. But if you're just flogging the guy over and over again, give him a break, because every time you shock the person, it's not 100% healthy either. It's not a totally benign thing. So yeah, if you're not making headway and you still got VF on the monitor, you don't necessarily have to shock the guy every couple of minutes.
So I think we thoroughly covered what high performance CPR is.
When should the Lucas be played?
So I wanted to talk about it because I spent a lot of time this afternoon thinking about that's a good question. When should you, from an evidence-based standpoint, which there's not, when should you actually put on the Lucas? Is it right away? Do we wait 4 minutes? Do we wait 20 minutes? Do we only put it on if we're going to transport? Because putting the thing on is it's an intervention, and like every intervention, it's got downsides to it, and it's mostly that people have a hard time putting on the Lucas if you're not really practiced in it. And even folks that are really practiced in it, that's 10, 20 seconds when you're not doing chest compressions. And then you got to get the thing to work.
Variability between patient habitus.
Yeah. If the thing doesn't work, then you've invested 40, 50 seconds into putting this thing on there that you can't use. Chest compression time that you're never going to get back. So what I was kind of thinking was going back to like the priority based or the time based priorities that we've tried to introduce to people, which is in your first couple of minutes, your priority is to give a shock if you at all can. And let nothing let nothing interrupt you from that. And after that, you can start worrying about airways and intubation and IVs and that kind of stuff. But so right away, focus on that. When does the Lucas fit in there? Well, it probably doesn't fit in there in the first couple of minutes. Your first move should probably not be to put the Lucas on. Your first move should be to do good chest compressions, get the monitor on them, try to give a shock. In that second, that second phase, that 4-ish minutes after that, I think that's the time when you can start thinking about it. But what I kind of came up with was it sort of depends on if you're in a resource-rich environment or resource-poor. If you've got a lot of firefighters standing around that you trust to do great CPR and you can switch out frequently, then you can delay putting the Lucas on for a long time. Because again, if you take the best human CPR, as long as you're doing the best human CPR, it's as good as the Lucas. So you don't have to put the Lucas on somebody until you're ready to transport them at that point, basically. That's if you're in an environment where there's lots of people. If you're out in the middle of Powell County and you guys are running one person, one guy and maybe a chase car, if we make that happen, and then an ALS provider and a BLS provider, or if you go out with just 2 people, as we've had, not infrequently, it's probably relatively soon. No more than that case in my mind. It's probably no later than 4 minutes. And why 4 minutes? Because that gives Floyd 2 minutes of CPR and gives Ryan 2 minutes of CPR. And you're probably tired after that. And that's probably when you're not able to do effective CPR anymore. So that's, I would say your priority changes because now it's an issue of fatigue and you actually got to get the thing on fast enough to be able to do good CPR. That's my opinion. So if you're resource rich, you got lots of time, put it on right before you transport the person, but don't do it before that. If it's just you or it's just a couple of people, you got other stuff to do. If you can offload that early, that's cool. Still not within the first 2 minutes, but probably by the first 4, you ought to be thinking that thing ought to be on if you're going to do it.
It takes a lot longer to put the Lucas on than most people realize. They think they're a lot faster than they really are.
So in cases where we have implemented all the facets of high quality CPR, we've done our shocks, we've done the best CPR that we think we're doing, and we're still in a persistent shockable rhythm, so like persistent VF, where do we begin to diverge from the norm there? Or what would be the most high yield treatment in that setting?
So refractory VF is sort of interesting character. It's cool because it's like encouraging because, hey, the guy didn't progress into asystole yet. So like, that's great. That's great. That's what we're supposed to do. But what do you do with it? I think there's a couple of things. And, if you say refractory VF, what everybody thinks now is double sequential defibrillation. And that's, the jury is definitely out on it, but I lean towards probably not, honestly. I think there's some other stuff you can do. So number one, the question is, why are they refractory? Is it that we're doing okay CPR and just not quite good enough CPR? And maybe if we gave them I actually believe that epi probably makes a little bit of a difference if used the right way. So maybe this is somebody that needs just a smidgen more epi to get their hemodynamics back so that we can mount a good blood pressure so that we can get them, a little bit more coronary flow and get a little bit better that way. So maybe we just need to improve CPR a little bit. And then when we shock them again, something else will happen. If it's something like, a coronary lesion that is just limiting blood flow, you're not going to fix that. And so that's where we were kind of talking before, like maybe that guy, you lay off for a while and you try to take him someplace that you hope will do something. Maybe it's a cath, maybe it's put him on ECMO. But for the most part, wailing on this guy with your electricity over and over and over again, probably after the third or fourth shock, unless you've got something drastic that you've changed, there's probably not a great reason to keep doing it. So what else can you do? Well, one thing you could change is the placement of pads themselves. Folks will bring up that. And usually when we jump onto a patient, the inclination is to get the pads on quick. And that's probably the right thing to do, but it usually ends up, like antero, mostly antero, honestly, but maybe anterolateral, something like that. And that may not be the best vector and it may not give you the most electricity delivered to the patient or to their myocardium anyway. So sometimes just changing the placement of the pads themselves, putting one, anterior posterior or something like that. Once you've given it a couple of shots and if it's not working, then changing that vector may depolarize more tissue or may change it in a different way and be just enough to actually terminate the fibrillation. Now you may go into asystole after that, but at least it stopped the ventricular fibrillation part. So that's one option. And probably there's something to be said for that more so than the double sequential defibrillation. The double sequential defibrillation, if you hear what most people say, and honestly, I've not really investigated it, the idea is that you deliver a lot more electricity to the heart and along a different vector, and hopefully you depolarize more myocardium, and subsequently the fibrillation stops. It probably more has to do with that changing vector than it does having two defibrillators, I think, because you're never really going to get it exactly right, and you're not going to get the shock timed exactly right. Even as close as you can come to pushing the button at the same time, you're going to be off a little bit. So if you think of the biphasic waveform, there's one there's a square wave that's positive and then one that's negative. And that's the way it's designed. It's designed that way specifically so that you get the most bang for your buck. You kind of screw that up when you add another defibrillator to it and you change that vector again. So you may put another set of pads on there and go 1, 2, 3 and push both buttons, and then they actually cancel each other out and it may not do anything. Plus, it voids the warranty on your defibrillator, so there's that. But probably, my guess is probably it doesn't actually help as much as we think, or folks have been led to believe it does. And it's more, hey, I put 2 sets of pads on them and it worked after that. And
are you
it
telling
probably
me
doesn't.
Small serious case reports should not be taken as gospel?
Yes. That's probably a reasonable way to say that.
Noted.
I think there's a lot of data saying that double sequential defibrillation actually does terminate the rhythm, but it hasn't really made a difference in terms of meaningful outcome.
I don't think it's always a clinically encouraging.
But I think by the time you get to that point, if you've given 5, 6, 7 shocks and nothing's working, you've got to try something different. But I think the first place to try is what you said, changing up the pad position, changing the vectors. For those that are listening who don't know what this double sequential defibrillation is it's taking 2 monitors, 2 sets of pads, and putting both sets on the patient, charging both monitors to their maximum energies, and pushing the shock button on both almost at the same time. You really can't hit shock on both at exactly the same time, but it usually ends up in one shock following the other in quick succession. So you're not adding more energy. So what you're really doing is changing the vectors, and the goal is that you need to depolarize a certain percentage of the myocardium for a defibrillation attempt to be successful. So that's kind of what you're doing with double sequential defibrillation. What I see a lot of people do is they just start with enterolateral, but the lateral isn't usually lateral enough. It's like more anterior, and they need
it's kind of like entero side boob, essentially.
Yeah. So you're like not really sandwiching the heart, and the goal of pad positioning is to sandwich the myocardium. And I think that's kind of why like enteroposterior is probably going to be more successful, as long as you don't like put the pad over the spine. You really want to sandwich the heart, and you don't want a lot of bony stuff in between the pads.
Yeah.
Now, is there a role for medication-assisted termination of this? Like Esmol or something comparable?
Well, what have you got against amio? No,
terrible.
So all the drugs work kind of the same way, which is they're trying to terminate VF, but they sort of work to varying degrees exactly the same. So we kind of get away from the drugs, and amio's kind of falling out of favor. Lidocaine's probably, lidocaine's still out there. It's probably as good as amio in terms of that stuff. And I think I can't remember the name of the study, but it just came out maybe a year and a half ago.
Amio, lidocaine, percotamide.
Yeah.
And
placebo,
yeah. Letters are hard.
Good old placebo.
It's my favorite drug.
But yeah, is there something else you could do? Well, if you're at that point, it's kind of anything's out there. Just like the double sequential defibrillation, like there's nothing about that that's actually evidence-based. It's just some dude thought it was cool, so let's try it. And again,
I think it's cool.
just like Floyd said, I think if you're going to do it, instead of getting two monitors together, if you're thinking that might be a thing, start with just putting another set of pads on and then switch it over and see if that doesn't work first before you go breaking a monitor.
That's probably more sound for you too.
Yeah. And by the way, the company can come back and look and determine that you actually did that. So if you think you're going to lie to them and say like, "Oh no, we never did that double what? Who? No.
Never heard of her."
Huh. Yeah, I actually talked to a physio rep who was like, "Yeah, we're not going to like pay for anything if this breaks."
It's good to know.
The other stuff you could do that you don't think about real often, beta blockers work. So like Esmolol, we don't use Esmolol outside the hospital a lot, but you theoretically could do it. It's a good antiarrhythmic. It's good at shutting things down in general. And so an Esmolol, good shot of Esmolol will potentially terminate VF. Same thing. The times I've used it anecdotally or seen it used by other people, it did terminate what seemed to be a persistent VF and put the patient in a bradycardic PEA that they were unable to resuscitate the patient from. But who knows if that would have happened or not. So it does it stop the fibrillation? Yeah. Does it improve outcomes? I don't know that we've seen that yet. But again, by that point, the person's probably pretty far into it. You can try doing some other stuff. Just like TPA, there's no good evidence that TPA helps in massive pulmonary embolism that causes cardiac arrest. But that doesn't mean that it doesn't work. In some folks, it probably does. But it's not going to work for everybody. So,
are these patients good candidate for ECMO?
The VF guys probably, yeah. Because most of the guys, if you can get somebody to the hospital in VF, it means there's probably enough protoplasm and probably enough gumption in their heart and in the rest of their body that there's something left to save. If you think about most of the people that you guys transport to the hospital, and I say you guys, but EMS in general, most of the people that we bring in, we get them in the hospital, and our survival rates from folks that are brought in are pretty low. But that's usually because they've been resuscitated, hopefully on scene for a while, and then they get delivered to the hospital only when nothing else has worked. But somebody that's in persistent VF, the mantra that nobody in VF dies is probably realistic, and it's probably a good thing to latch onto. If they're in VF, there's something there still. There may not be a lot there. It may be super difficult to figure out what's going on, but there's something that's going on that's keeping this person at least halfway alive. Whatever you're doing is kind of halfway working, even if it's not working absolutely as much as you want it to.
Okay, that makes sense.
So the premise, I think, behind the beta blocker administration in refractory VF is that the patient could be in an electrical storm, or we just give so much epi. Either way, the premise is that you give a beta blocker to keep the alpha effect of epi, but to negate the unwanted beta effect, right? So if the patient's in this electrical storm, we give a lot of catecholamines that can further make it worse. And I think going back to what you were saying about providing ECMO for patients in refractory VF, that's still not practical or realistic for a lot of departments across the nation. There are some hospitals, some cardiologists who will take a patient intra-arrest with ongoing CPR using the Lucas device to the cath lab and try to reperfuse the heart that way. But again, it's not practical for a lot of our folks. But if it's practical or if it's happening in your area, then that's something that you should talk to your facilities about and find out if it's a thing. Like, if we have a patient, if we've identified that within the first few rounds of CPR that they're in VF and they're not converting, maybe this is going to be a patient that we want to think about moving sooner rather than later. We're going to talk about moving patients a little later, but I just want to throw that out there.
Yeah. And I should mention too, when I said consider, see if you can optimize their hemodynamics, see if you can give them a little more epi. I didn't mean give epi every 2 minutes until you run out of epi. That's an important point, because probably once you've established that it's pretty persistent, giving a bunch more epi probably only makes things worse, as you kind of alluded to. So if you want to try one dose of epi and see if things get better and then you can chalk them out of it, cool. But after that, if they're still in VF, you got to kind of watch it a little bit. And that's probably one of the dangerous things about epi, is that we usually don't really know what it's doing. We don't know how much is enough. We don't have any way of monitoring it without an A line, which I haven't seen you guys put one in yet, but maybe I just missed it. Yeah, it's
is that
tough
a challenge?
See the ITLS stance on finger thoracostomy that came out not much more than a week ago.
So you're saying it's possible?
So you're saying there's a chance?
There's a chance. Let's just say there's a chance.
So in regards to epi, we, like you were saying, we don't know the optimal dose and we don't know the optimal timing of epinephrine administration, but it's probably a much smaller dose than we're used to giving and a much longer, like, we need to extend the frequency out just a little bit. And you said we don't have an A line, but there is something that we do have that might be useful, which I think that thing is end-tidal CO2. I think if, say, the CO2 is low, less than 20, we know that we don't have good perfusion in the lungs, and then that might be a good time that we would want to administer epi. But I think that we might see something in the future where if the end-tidal is greater than 30 or 40, like, we withhold epinephrine because we know that there's good perfusion to the lungs. Do you think that might become a thing?
Yeah, absolutely. Because, like you said, all you're doing, if you do really good CPR on somebody, enough to get an end-tidal of, say, 40 or something like that, and the person hasn't actually developed a perfusing rhythm yet, what their body will actually start doing is auto-regulating again. So you see it in, like, if you instrument a pig's brain, when you initially start off with the patient, the pig fibrillating, once you start doing effective chest compressions and really restore some perfusion back, all of a sudden, like, the blood flow of the pig's brain kind of changes a little bit. And there's no reason to say why that would happen, except that as it's sort of coming back online, just like the rest of the body tissues are thinking now, oh, okay, well, I guess I can do that myself. So at some point, if you're able to provide really great resuscitative maneuvers, then you may be able to actually get a little bit of autoregulation back. And maybe you don't need epi every 2.5, 3 minutes like we tend to give it. That's not going to happen most of the time, by the way. But
So we'll probably need some epi. We just don't know how much.
Right.
So we've talked a lot about like VF and VT patients. You've developed a protocol for us that takes a rhythm-based management to rhythms other than VF, VT. Basically, the only other rhythms are asystole and PEA. But for those PEA rhythms, we differentiate between narrow complex PEA and wide complex PEA, and we have to treat those accordingly. Can you explain to our listeners why that is and how the width of the QRS can potentially tie in to what could be going on with the patient?
Sure. And I'll preface this with there's a lot of good evidence that says, for instance, one of the antidotes that you look at is bicarb. So there's a lot of evidence that says bicarb probably doesn't do anything. There's some studies that actually show if you get bicarb, you're more likely to not survive or to survive with a terrible neurological outcome. So I wouldn't advise giving bicarb all the time, but the protocol that you're referencing specifically says basically after you do your resuscitative stuff, look at the QRS complex, and try to use that to start guiding your therapy a little bit. So what could it possibly be? If your QRS is wide, it basically means there's some sort of interventricular conduction delay, probably. If you've actually got a QRS complex, there's something that's slowing it down. So it could be just terribly ischemic, like dead tissue. That we're not going to fix. We're not going to do a whole lot about that. So you kind of don't have anything to do with it. And again, this is kind of like after you've done everything else, what should you be doing? Initially, if they're in a wide complex initially, it could be that they've had, a long ischemic event, or they've been hypoxic for a long time or something like that. Or the thing that we could fix would be maybe a TCA overdose, or if they're hypercalcemic not hypercalcemic, hyperkalemic, that you might be able to do something about. And you may be able to affect it in a profound way. So in that guy, because you don't know, because we don't have the benefit of checking, essentially instantaneous point of care labs out in the field, if we go ahead and just treat that, assuming that it might be hyperkalemia as the reason for their arrest, if they have a persistent wide complex that doesn't have a pulse with it, that seems a reasonable thing to do if you've done everything else. You probably shouldn't just throw bicarb at somebody if just for the sake of doing it. Likewise, throwing bicarb at somebody just because they're acidotic is also not a good strategy, because it won't really help, and it probably will actually make them a bit worse. And we could talk about that at some other point. But bicarb is never the answer, except if maybe they're a wide complex and you've ruled kind of everything else out, or you've made that like your last ditch effort. Then I think it's probably okay with that rationale for us to say well, it could be as potassium. Potassium kills a lot of people and we just don't realize it. So let's try to treat as potassium and see if it gets better. Likewise, calcium is a good inotrope. Calcium will fix things like other toxins. So calcium channel blockers, that kind of stuff. Those guys will be helped by some calcium as well. Could the arrest be due to that? Yeah, it could be. And again, not everybody should get a bunch of calcium, but that guy that's got a persistent wide complex PEA rhythm after you've done everything else, I think it's reasonable to say that let's try that. Let's see if that works. Now, we haven't done that very much out in the actual field. That's been in the protocol for a while. We haven't actually used it very often because it's not very common. Usually by the time you're getting to that point, they've either gotten a pulse back or it's asystole, realistically, because that's a ways down the road. Some of the other stuff you can look at too, if there is no interventricular conduction delay, if the complex is narrow, that usually means, okay, that either it's just that, the myocardium is just not generating a force, which could happen, I suppose, or there's some reason that you're not getting perfusion out of it, meaning there's an obstructive cause, or the patient's just so hypovolemic that you're not able to actually eject enough blood out. So in those narrow complexes, that's where we're usually saying, hey, there's probably something else going on, especially if they're not, if their rate is greater than 40 or 50. It's probably that there's something else going on, and it's maybe not the heart itself. Maybe it's that the person's really hypovolemic. Maybe they've been bleeding for a while, or maybe they've got pericardial effusion that's causing tamponade or hemopericardium, or maybe they've got a PE, maybe they've got this or that pneumothorax. In those cases, it's reasonable to try to relieve the obstruction or what you presume to be an obstruction and relieve the hypovolemia rather than trying to give a bunch more drugs. So that's kind of the thought behind it.
Cool. So once you've done everything, why complex PEA? It's probably okay to try some calcium, probably okay to try some bicarb. But I think that, obtaining a good, thorough history will also really help you target your treatment. If the patient's on dialysis and they've missed a few days of dialysis and now they're in cardiac arrest, that's a pretty good indication for the administration, for the empiric administration of calcium and maybe even some bicarb.
Oh, yeah, absolutely. If they're in VF and the person says, or the wife says he's a dialysis player, get the calcium. It's fine. Do it. Just do it. Because in that guy, that may be somebody that you actually can treat.
Yeah. So those are like when we talk about H's and T's, these are stuff that we should really, I think, like hone in on and spend a little more time talking about, because these are people, if they're on dialysis and they miss some appointments and we get a bunch of calcium on board, then that person can survive.
Yeah. Likewise. Wife says he's got something wrong with he's got a prolonged something his doctor kept telling. Well, you mean prolonged QT interval? Okay. That person should maybe it's okay to just go ahead and give that person magnesium. Not everybody needs magnesium, but like you hear about it. And how long is the rhythm strip on that screen, on the actual monitor? It's like 3 seconds or something like that. It's really hard to actually pick out torsades on a short little defibrillator screen. It's kind of hard to pick it out on a big hospital monitor that has like 10 seconds worth of data on it. So if you think that's it, like that's still okay to do. Don't be afraid of it if you think that's the actual cause of the patient's problem. But for the most part, none of the other stuff, the bicarb, the calcium, beryllium, mag for the most part, nothing else really seems to empirically help if you don't have a good reason for treating that rhythm.
So this is kind of the question of the hour, should we transport cardiac arrest patients? And
no.
So,
sorry.
Yes.
I think we have been wanting to talk about this all night.
This is really the question we should have started with first and just gotten it over. But should we take dead people, and is there a situation in which taking a dead person to the hospital may or may not be the right thing to do?
So probably we shouldn't take dead people to the hospital. People that don't have a pulse. And my philosophical reasoning for that is that, transport is a treatment. It actually is. People talk about bolus diesel. Well, it is actually a thing, because you're doing stuff to the patient, but it's got terrible consequences to it. So the minute you even say, okay, we need to go to the hospital, the focus changes from doing great resuscitation, like you should be doing, to how am I going to pick this guy up? He needs to be on a backboard. Okay, I got to get I got to get a scoop. Man, is he going to fall off? What do I do at the monitor? What do I do with my IV lines? Oh crap, we're going to get pulled on. God damn it, somebody get that dog out of here. Everything about the transport, it becomes all about the transport. Yes, exactly.
Steps.
How are you, man? Now we got to make sure the Lucas doesn't fall off. Has anybody seen the neck strap? By the way, do you guys ever use the neck strap on the Lucas?
When it's present,
if we have it,
no.
I try to use it whenever possible because it just generally makes life clear.
Yeah, I can count on one hand with 0 fingers the number of times I've seen somebody come in with the neck strap on the Lucas. So just
it's usually me like pushing up on the Lucas to keep it from slipping and in place.
Yeah, exactly. And that's the thing. You're no longer resuscitating the patient, you're moving the patient. Mm-hmm. And I will absolutely admit that a big part of pre-hospital care is moving somebody. Like that's super important. I absolutely agree. But in cardiac arrest, they don't really need movement for the most part, unless you're going to move them to do something that you can't do on the floor of grandma's house. And there are some things that actually make sense for, but for the most part, we're there to first treat the person, and then if you've got a reason to move them, then okay, move them. But we can do a much better job where we're at, generally speaking, than we can trying to move somebody. Okay, so is there evidence behind it? Sure. So the Koreans have put out some stuff. And one, if you read the paper that you think would most likely give you the best data, it says that if you stayed on scene for the prescribed length of time, or for what they called a relatively long scene time, extended scene time, and resuscitated them on scene, patients did significantly better, and you had a much better odds ratio for survival. Not that much better, but somewhat better. The problem with that one is their time frame was greater than 5 minutes or less than 5 minutes. So yeah, if you got on scene and left within 5 minutes, your chance of survival was less than if you stayed for more than 5 minutes. So that's something anyway. And says that if we focus on doing some CPR and doing resuscitative maneuvers, that there's probably a benefit to it. There's a review of the ROC data that shows if you stayed on scene for a little longer period of time, you had a little bit better outcome as well. And then probably one of the best ones, I think, or the one that shows it the most, was a study that compared the differences between folks in Osaka and folks in Seoul and how much time you spent on scene. So if you were on for a short period of time, which was less than 8 minutes, and an intermediate period of time, which was 8 to 16 minutes, and over 16 minutes, you compared all that, all those survival. Survival is the best, and survival discharge is the best in the group that stayed on, for the intermediate amount of time. So, and if you think about it, it's probably under 8 minutes, a little too fast. You're kind of scooping everybody and running with that. That's probably a little bit too much. Folks that are longer than 16 minutes, that means we flogged this guy for a long time, and they probably aren't going to survive to start with. So those folks are already out there. It's the folks that were kind of in that middle section where we did, 15-ish, 20-ish minutes of resuscitative efforts on scene that did the best. So that's about the best data set that's out there right now, probably, or at least the one that sort of makes that point the most frequent. But really, if you look at all the determinants of CPR, the high performance CPR, all that stuff, you can't do it while you're moving. You realistically can't. So there's not a lot of great data right now in terms of big numbers. But there's a fair amount of stuff that says commonsensically, this probably doesn't work. Of course, common sense gets us into trouble, but that's what it says right now. And that's my thought on it. Don't transport your cardiac arrest patient unless they have a pulse, is probably the best way to say it.
Now, what about with pediatric patients? Is there a survival benefit to essentially pulling a body snatcher and throwing it in the back of the truck and driving like hell? Or is it worth their survival benefit to actually stay and work them where they fall?
There's a benefit to working the patient on scene still. The problem is with kids, there's social aspects that you have to get rid of, in that in our protocols, I've said I don't want to call a kid in the field. And it's not that I think that kids are, special or something like that, or more deserving of transport than adults, because I really don't. The problem is that it's tough to lose a kid, and it's tough to lose a kid in your house, which is where a lot of kids die. So I don't want to put the family through the social issue of that. And also more resources are available if your child dies in the hospital instead of at home, generally speaking. So that is a big social determinant to it. There's also honestly a determinant in terms of EMS provider, like, is this person comfortable working a kid too? And I don't think that being uncomfortable is an excuse to do crappy care, but let's be realistic. Folks lose their shit when there's a kid involved, and we don't do as good a job, and we tend to freak out. So in that case, if I think the person is going to freak out, or if I think they're not going to not do a good job, I would say, okay, if you honestly can't get it together, it's your job to get it together. But if you can't, get them to the hospital. In this case, that's honestly okay, because it doesn't happen very much. That doesn't mean that you shouldn't do CPR in the meantime. That doesn't mean that you in any way should compromise on the quality of resuscitation. But if you absolutely cannot function under that circumstance, then okay, I'll buy it. But best survival is still, if you're going to work the arrest at all, work it where you find it. Focus on doing great CPR, great resuscitation, and then take the patient to the hospital once you've gotten a pulse back.
Okay.
And I think so many people are against calling patients on scene. They're adamant that once you start CPR, you have to transport, which I don't think that we're going to be able to entirely convince everyone otherwise. I think we could probably convince most people that we should probably stay on scene a little bit longer before we initiate that transport, if you're going to transport.
Yeah, I agree. And if you want, you can talk about how long can we stay on scene before we're sure that it's okay to call it. But yeah, absolutely. If you're going to do the resuscitation, if you're going to put the effort into it, then for God's sake, do the resuscitation. Don't do the transport. The transport can wait. Focus on getting the guy back if at all possible.
I think if you're going to transport, 20 minutes down the line after you start working a patient, then on most cardiac arrest, everything becomes pretty routine. Then it's just, you find yourself with some extra time. I don't think that we should be transporting most of these people, but I think if you're going to transport, that might be a reasonable time to do so.
Mm-hmm. I think that's a good time to start talking about the decision, certainly. And we probably made up the 20 minutes to start off with. The first person that said you should stay on scene and work for 20 minutes probably had no reason for that. They're just like, oh, whatever. You can kind of justify it in terms of how many rounds of CPR is that? Well, if you get them down there and then you establish an IV, and you could probably give about 3 rounds of epi at that point. And so there ought to be, 5, 6, 7 rounds of CPR that ought to have been going on by that point. Hopefully a bunch more than that, but let's be realistic. What actually happened? You'd say you get at least 3 doses of epi and a bunch of CPR then, and a chance to manage everybody. So you can justify it that way. If you look at it in terms of are we making the decision to transport versus call it? In Kentucky, it's a little bit difficult because legally you're not allowed to terminate anything other than asystole in the field. Just can't, unless they're a DNR or they have an injury incompatible with life, which is not all that many people, as we've kind of talked about. But if you look at the actual survival curve, there were a couple of good studies that came out in 2016 that both showed essentially the same thing. At 20 minutes, you've picked up 90% of your survivors. And even, the percentiles are one thing, but whether the person's in a shockable rhythm or a non-shockable rhythm, whether it's witnessed or unwitnessed, by about 20 minutes, you've gotten, again, 90% of the survivors. If you want to take that out to 95%, you probably got to work them until 35 minutes. If you want to take it out to the point of medical futility, which is 1%, that we don't terminate anybody that we don't terminate anybody who's going to have a neurologically good outcome. If you want to make sure that we don't do that, you probably got to take it out to at least 40 minutes, probably 45 or something like that.
And there's still outliers.
Yeah. That's going to be the problem. If you look at those curves, everything falls off at 20 minutes, and you're talking about getting 99% of, in the case of unwitnessed, non-shockable rhythm that didn't get bystander CPR, which is a lot of the people that we see. In that case, you're talking about a baseline survival of 2%, 1%. And so you're talking about picking out 99% of 1%. And that's what you're buying by doing another 20, 25 minutes CPR on scene. Now, in shockable rhythm, that actually goes up quite a bit. And folks will, as I kind of mentioned before, you can do good CPR and push that number out a long way. So in that case, if they're VF, VT, something like that, if you can keep that going, there's probably a good reason to do CPR for 40 minutes, 50 minutes, something like that. Essentially push it to the point of futility where you absolutely can't do anything else and you've exhausted all your drugs and your BC's yelling at you to get off scene because there's 3 other calls that are waiting and the ambulance has run out of gas because it's been idling that long. Those folks, it's probably worth it to do that. PEA, asystole, something like that, probably not, because you're picking up about 1,000% of survivors if you do that.
I think for those people with a chance of a meaningful outcome, like witness arrest, bystander CPR, VF, VT, they keep extending that time out longer and longer and longer because they keep finding out, hey, more people are surviving if we just spend a little more time doing these high quality interventions, and we could save more people.
Yeah. I think to a large extent, I kind of said before, this cardiac arrest resuscitation stuff is mostly a BLS thing. And that's still true. most of the stuff can be run by a BLS crew, and they can do great CPR and they can do great resuscitation. They can't give a lot of drugs for the most part, but they can do almost everything else and do it really well and not get kind of bogged down. But this is where it's really incumbent on our ALS providers to make good decisions too, because you guys are the ones who can look at it and say, you know what? She's 88 years old. She's been in a nursing home for 15 years. She was asystole when we got here. She's asystole now. 20 minutes is what Lubbers said as our goal time to make sure that we got all our stuff done. And it's 20 minutes and she's still asystole. I don't think this person's got a chance. Like, that's a reasonable thing at that point.
Absolutely.
Versus it's 20 minutes. The guy is in persistent VF, and not that you could call it. You could say, I guess you could say he was in VF for 18 minutes and now he's PEA. And now it's 20 minutes. Should we keep going? Well, yeah, probably, because he's 20 years old and he clutched his chest on a treadmill, and you've been doing good resuscitative efforts since then. That sort of thing, given somebody on scene the ability to actually make a decision instead of just having to follow the protocol, I think that's where your guys' skill is really most useful. It's not really the giving drugs. We could honestly put an EMT out there with a little bit of training and let them give drugs. It's not really that. It's the decision making otherwise. Not to crush EMTs, because they're awesome.
Last thing I really wanted to talk about before we have to wrap the whole thing up is something that people bring up to me all the time. And the question is there a role for endotracheal intubation during cardiac arrest? Because I remember years ago when I first became a paramedic, there was this huge push for, hey, we don't need to intubate anyone during a cardiac arrest. We should just be dropping a supraglottic airway. But I think that may have changed a little bit. What are your thoughts on intubating people during cardiac arrest?
Well, the number one thing is you have to manage the airway. You know, we went to CAB, and I think that not scared a lot of people, but it gave a lot of people license to say like, oh, well, it's compressions, airway breathing. I don't actually have to do anything beyond the C, which is dead wrong. If you don't ventilate somebody, they are going to die, almost certainly. They're probably going to die anyway, but you're just going to put the nail in the coffin if you choose not to ventilate somebody in toto, or you don't figure out a way to manage their airway. So airway management is still critical. You still got to do it. The CAB thing is just to de-emphasize it a little bit and say you shouldn't stop compressions in order to be able to manage the airway. So I wanted to say that first because it's still super important.
Let's say you don't stop compressions, which by now we should not be stopping compressions to do anything other than shock the patient, or, unless they have a pulse, but we still see people do it. But let's say all things being equal, you don't stop compressions to intubate. You don't stop compressions to place a supraglottic. What do you think about it?
About should I place a supraglottic or should I intubate the guy?
Yes.
Yeah. It depends on what your priority is. Again, if you roll up and you decided that you're going to make most of the resuscitative stuff the BLS kind of maneuver, then I think it's okay to probably start with either BVM or, again, in Kentucky, EMTs can place a supraglottic airway. I think that's okay to say initially, okay, I don't care what you do, BLS partner, you manage the airway. Do whatever you want for right now. If you run into problems, holler at me and I'll try to intubate him right off the bat. And then you can get stuff kind of, stabilized and settled down a little bit and get your IV and give him a dose of epi. And then you can try to intubate him if you want. I think that's a reasonable thing to say. The data that's out there would say that ET tubes probably are associated with better survival than supraglottic airways, whether it's a King or an iGel. Kings are the ones that mostly get used just because they've been around a little longer. But the data would probably say survival is a little better if you use an ET tube. In the Hasegawa study, it said that neither one is as good as just bagging the patient, but it's an association. You don't really know what caused it exactly. Was it that those folks just really did great bagging and then got the patient back quickly? That may have something to do with it. There's always that confounder in there. So if you're going to be completely evidence-based, you'd say if you can survive without an ET tube or any advanced airway to start off with, and you can just bag the patient, great. Again, with the exception, just like with a Lucas device, this is really good bagging. This is folks that train on this kind of stuff. You can't expect that everybody out there is going to do as good a job. So there's that. Intubation itself certainly is fraught with peril in that it's difficult to do and it takes time that you're not ventilating the patient potentially. And then afterwards, it makes it kind of easy to hyperventilate the person, which you can't ignore. So there's problems with it. But if you had to go strictly by evidence, I'd say if you're going to place any advanced airway, eventually it probably should be an ET tube. And if you have the people to do it right off the bat, it's probably okay. Once you've given a few ventilations to kind of get things started, it's probably okay to place an ET tube. You shouldn't be, I guess I want to say you shouldn't be scared of intubating the patient if it's between that and putting a supraglottic. If you can just bag the patient, that's totally cool too, for a while.
And I like what you said about like them de-emphasizing ventilation and making it CAB, because I've actually heard someone say, well, we don't need to ventilate the patient. We should just focus on compressions. And there's this huge debate on passive oxygenation. Should we just use high flow O2 via non-rebreather nasal cannula for like the first 10 minutes? And my argument against that is that, it's going to take you a few minutes to get there. And if all the bystanders did were CPR, then the lungs have probably collapsed a little bit and atelectasis has set in. And then you have no air, no oxygen getting to the lungs. And so at some point, you're actually going to need to squeeze a bag to reinflate those lungs to be able to oxygenate the patient.
Yeah. I think it's a bridge therapy like any other. I think all too often in EMS, we hear something new or we look at a novel concept like, oh, we'll do this instead of doing that ever. That's not necessarily the case. This exists in a continuum.
Yeah.
Yeah.
If you have a witnessed arrest or something like that with reasonable downtime with bystander CPR, throw them on an underbreather, get someone on the chest, and put your pads on. Then you can start rotating people through the bagging. Doesn't mean they have to sit there for 10 minutes without ever having a seat receive an artificial ventilation. Same thing with the supraglottic or the intubation. Intubation is obviously probably more ideal and probably, like Dr. Lubbers said, associated with an ultimately better survival. Doesn't mean we have to jump straight into that boat. There's nothing that, at least in our protocol, that says an EMT can't place a supraglottic airway and then the decision be made to intubate the patient. And that decision is going to be completely dependent on the paramedic and the clinical circumstance. But I like to intubate people. I don't know really anyone who doesn't like people, but it's not always the best thing for the patient. It's not always the best thing in the environment. If I'm the only paramedic in the county and I've got 6 EMTs standing around me, throw a king in, man. I got a resuscitation to run. Ordering of priorities. If I've got 4 paramedics and 2 EMTs, I'm probably going to pick up a laryngoscope blade.
Yeah.
That's just me.
I think a big part of it is we don't know. We really don't know which is better, which is okay. There's a study out there that probably is hopefully going to answer that question in the same way that the epi studies were going to answer the epi question, and still we don't know.
So the airways trial?
I believe so, yeah.
Yep.
Yeah. So hopefully we'll get more data. But right now I don't know that we know 100% which one's better or enough to say you should definitely do X or Y. I think we've got enough to say you should definitely manage the person's airway, and it's not okay to let the person go without ventilations because they get profoundly hypercarbic and profoundly acidotic and they won't come back. All the other stuff you're doing, airway is still important. It's just probably not important in the first couple of minutes, and it's probably not important enough to stop a bunch of CPR for you to intubate for.
I think that's absolutely going to be the key difference, is that you can't, or we collectively can't just get focused on one particular intervention. This is, okay, we must get involved in the minutiae of intubation. Or we can just be like, it's an option. It's probably better. But what's the overriding priority? Is it having a patent airway? Is it delivering ventilations? If this is, in my opinion, and feel free to rebut, is that the means justify the end in this case. I'm not saying you should go crank every cardiac arrest you roll up on, but I mean, although it would be cool, if you have a patent airway and if you're able to deliver effective ventilations, you have accomplished the goal. There's risk and benefits associated with that, but that is ultimately the goal.
Yeah.
Well, I do tell people that I don't care what type of airway they establish, as long as they don't stop compressions to do it, and as long as they don't hyperventilate the patient. But I might have to modify that statement a little bit since you mentioned cracking everyone.
Our medical director is in the room with us right now.
It's okay. He's not really paying attention. He's doing his own thing.
Good.
Can I say one more thing?
Absolutely.
This was something I should have said during the last section where we were talking about transport. The one thing I did want to kind of get across was that some folks we should take to the hospital kind of right away, because I pretty profoundly said, no, don't take anybody to the hospital. Mm-hmm. A couple of people will probably benefit. One is if you pull them out of a burning building and you don't have a cyano kit available and they're in arrest, they probably need to go someplace where that has the kit available, because that may actually make a big difference, even if they're down for a while. So somebody, like I said, somebody you pull out of a fire needs the hydroxycobalamin or some sort of, if you have the Lilly kit sitting around or whatever, they need that kind of thing. If they're an OB patient and their fundus is at the belly button, they realistically should get a perimortem fetal extraction within hopefully 4 minutes of their arrest, which is never going to happen. But those folks should probably be taken directly to the hospital, because getting the baby out at that point is important for mom. It's important to try for baby too, but it's super important for mom if at all possible. If the trauma, plus minus, we've got a whole different trauma arrest protocol. Those guys might benefit from transport if there's something you can do about it, but you should probably stay on scene and do most of the stuff first. But if it's a stab wound to the chest that arrests in front of you, if you can get them to the hospital quickly so they can get in and fix that, whatever it is, that person might benefit a little bit. And I guess the last thing is if you have an artificial heart, which nobody actually does. And I'm not talking about an LVAD. I'm talking about an actual artificial heart, which there are a couple of them floating around. That person, probably chest compressions aren't going to be very effective. So you can transport that person and hope that they can do something to fix their artificial heart. And that's it. But I did want to mention those special cases. Keep in mind, most people won't survive a trip to the hospital. So if you put them in the ambulance, they're probably not going to survive when they come out on the other end.
And if you drive like an asshole, you probably won't either.
Yeah.
Well, that wraps it up. It was an honor having you on the show, Dr. Lubbers.
Pleasure is all mine.
Dr. Lubbers, you want to give a closing statement?
I thought my most won't survive to the hospital was pretty...
I like it.
Let me close it so I don't have to delete any more shit, okay? This is Floyd and Ryan saying bye. This is Floyd, Ryan, and Dr. Lubbers saying bye.
Jesus Christ, you left him out.